Dr. Christina Azevedo is an associate professor of neurology at the University of Southern California, and she's here at the ACTRIMS Forum, where she presented on the updated McDonald criteria for diagnosing MS, and we'll get into some of that in just a moment. Welcome to the ACTRIMS Forum, and welcome to Real Talk MS.
Thanks so much. Thanks for having me.
When we talk about diagnosing MS, we're talking about the McDonald criteria. Can you explain what that is?
So the McDonald criteria are a set of criteria, a set of findings that we look for in combination to make an accurate diagnosis of MS. And they've evolved over the years, so it's usually some combination of symptoms, exam findings, MRI findings, and perhaps spinal fluid. And of course, the exclusion of other illnesses or conditions that could cause white matter lesions and neurologic symptoms. We put that all together to make a diagnosis of MS.
And you mentioned they've evolved over the years. They have recently evolved. Can you talk about some of the updates?
Yes, so every so often they do update the criteria as science moves forward. So there was a committee that was convened last year, 2024. The publication is expected this year in 2025 for the latest version of the criteria, which had some pretty important updates. So one of those is that we can now count the optic nerve as a location in MS, which historically has not been the case. So patients present about 25% of the time with an optic neuritis, and about half the time along the way they'll have one throughout their disease course. But historically, we haven't been able to count the optic nerve as one of the locations we look for. There have been 4 locations where we traditionally look for demyelinating lesions in the central nervous system, but the optic nerve was not one of them because the field felt like there wasn't enough specificity because there's other illnesses that can cause an optic neuritis. So a lot of studies were done. Essentially, we're now able to count the optic nerve if it's the initial presentation as a location, which is very helpful for many patients. I think that'll lead to earlier diagnoses in patients presenting with an optic neuritis. We've added a couple of imaging markers this year, which are, we hope, more specific for demyelination. So this is called the central vein sign and paramagnetic rim lesions. We will be able to diagnose MS in patients even before their first clinical symptom in some cases. This is a group of patients that historically has been called radiologically isolated syndrome, and I've been involved with that group that's been studying them for a long time now, fortunately. And essentially many of those patients have MS, it's just that they haven't had their first symptom yet. So many of those patients now can be diagnosed even prior to first clinical symptom, which is a huge advance. And we've also added another biomarker in the spinal fluid, kappa-free light chain, which can assist in the diagnosis as well.
Can you talk about the updates related to MRI imaging and distinguishing whether a lesion is demyelinating or not?
Yes, so the advancements in imaging are really to add specificity to the diagnosis. And so traditionally what we do when we have an MRI scan is we see white spots and we look for them to be in a certain size, shape, location. But we haven't taken advantage of things that we've known for decades in a way. So we've known for a long time, based on autopsy and pathology studies, that lesions in MS like to form around blood vessels. But we haven't used that with our imaging. But now, in the current version, we will. So we can use sequences that are sensitive to iron, because that's inside blood and blood vessels, to see blood vessels in really high definition. And then in one technique, you can take a blood vessel sequence and combine it with your FLAIR sequence, which shows the white matter lesions. You can basically overlay them and see how many lesions a patient has that have blood vessels inside. So with MS, we expect the vast majority of the lesions to have blood vessels inside, whereas with other conditions, it's not. It's the minority of lesions that will have that with things like migraine and small vessel disease. We hope that's going to be very useful, particularly in cases where it's not straightforward. Sometimes the clinical history or the imaging findings are not entirely textbook, and so we're hopeful that'll be very helpful in those cases to show us that the lesions are in fact demyelinating. And the other advancement, the paramagnetic rim lesions, is also based on iron-sensitive imaging. So this is to see lesions that we think have a low grade of chronic active inflammation inside around the edge of the lesion, which again, we haven't been able to see that with routine MRIs. We've known they're there for decades based on pathology, but now taking advantage of iron-sensitive imaging, because those cells with the inflammation also have iron inside, we can use an iron-sensitive image to show a rim around a lesion to suggest that there's inflammation there. So to make things more specific for MS and demyelination.
A moment ago, I heard you mention that updating the McDonald criteria can lead to earlier diagnosis. Can you talk about the advantage of getting an earlier MS diagnosis?
Yes, so we know that treating MS as soon as we can identify it leads to better outcomes in the long run. And so we definitely want to make this diagnosis as early as we can, but also as accurately as we can. And so we hope and think that this new set of criteria will help strike that balance between early and accuracy.
So let me ask you, what are you seeing in MS research today that excites you?
I am very excited by the focus on progressive MS. I think that's very needed in the field. And we've been fortunate to have so many advancements in relapsing MS and with drug development and so on, which can really prevent lesions effectively now. But we are waiting for something that targets progressive disease biology specifically, and hopefully we're seeing advancements there. So I'm very excited by that. And I'm also very excited by the field's focus on preclinical MS, so trying to understand the earliest events that lead to MS so that someday we can hopefully prevent this altogether.
I was going to ask you about the ability. How far away are we from the ability to be able to diagnose a patient with MS before they present with clinical symptoms?
So in some cases, as I mentioned, we can do that with what we used to call RIS patients if they happen to get an MRI machine for other reasons, such as having a headache or a car accident or something, and they happen to have the lesions, then we think many of those patients now do meet the newest criteria for MS and can be treated. But I'm excited by the field hopefully honing in on this preclinical phase, maybe starting 5 to 10 years prior to first clinical symptom onset. We and others have shown with MRI scans in our case, but also with blood markers, and people talk about prodromal symptoms starting years before the first symptom. And so I'm hoping that we'll see studies in the next phase of research that are really starting to screen perhaps higher risk patients maybe as a start to really identify lesions long before they would have come to clinical attention before.
I think a lot of people are hopeful when you see that patient in that state, you might be able to intervene with a high efficacy therapy, and perhaps they never experience those clinical MS symptoms.
Absolutely.
We're here with about 1,800 attendees at the ACTRIMS Forum. What's been your impression so far?
My impression has been that it's a very exciting forum and a lot of great research being presented, a lot of connections being made. That happens to be the theme of the meeting, but it's still nice to meet in person again post-COVID and really get to talk with colleagues and see where the field is moving and do it all together here at ACTRIMS.
Well, Dr. Christina Azevedo, I want to thank you for all you do to improve the lives of people who are living with MS. Thanks so much for talking with me today.
Thanks for having me.